name is Ryan McInerney. I'm with Cole Biomedical, and we're the company that distributes and markets the Combicath in the United States. The Combicath is a catheter that's being used widely in Europe and now in the U.S. For accurate diagnosis of VAP, ventilator-associated pneumonia, in the ICUs. Essentially, people have had issues with diagnosing VAP because the diagnostic tools have always been a little bit in flux. What a lot of people are doing is tracheal aspirates or sending sputum cultures down to the lab, which are notorious for having false positives, which leads to overtreatment of antibiotics, and also has a bit of a negative predictive value, which sometimes you can miss a bug because what you've got is a lot of upper airway contamination. Thus, what a lot of people consider the gold standard out there is bronchoscopic BALs. Using a bronchoscope to go down into the lower lung, get a BAL, do a lavage, and then send that lavage down to the lab. The infection, obviously, for VAP occurs down in the lower lung. Therefore, it makes the most sense to go ahead and get your sample there in order to determine the causative organism. The benefits of determining the right organisms are twofold. First of all, appropriate antibiotic therapy is very important. It can give you optimal mortality and morbidity for your patients. So if you can direct the proper antibiotic therapy from day one, that patient has a better chance of surviving, especially if it's late onset with some of the more nasty bugs that can cause some real problems. Secondarily, and just as important from a cost perspective, is by doing BALs, you can also eliminate a lot of false positives because the upper airway contamination of tracheal aspirates often yields a bunch of different bugs that aren't necessarily the causative organism down in the lower lung. Therefore, what you can do is rule out VAP with using BALs. A lot of times what people are doing now is bronchoscopically guided. What the Combicath is, it's a catheter that does a BAL, gets a lower lung sample, but it's blindly placed at the bedside by respiratory therapists across the U.S. and again in Europe as well. The key to this is it's a quick, easy, and simple procedure that allows you to drop a catheter down into the lower lung, do a lavage, and aspirate a sample right back into your syringe, and then you can send that down to the lab, and now what you have is a clean, protected sample of the lower lung. So it's a fairly simple and easy procedure, and what I'd like to do now is show you the catheter and also demonstrate the in-service techniques and the techniques used to put the catheter down into the lower lung and get a proper sample. Alright, now you're ready to go ahead and insert a Combicath. You've gotten the physician order to go ahead and do this, and now you're ready to start. Two things you need here at the University of Maryland are one, a Combicath, and second is the Combicath kit. Inside the kit contains everything you're going to need to go ahead and do this. The only thing that's missing are the sterile gloves as well as a mask to go ahead and do the procedure. Obviously these are size specific, so you go ahead and choose the ones that fit you. The Combicath is a sterile technique. Obviously we're not in the operating room here, but you want to use your best sterile technique. Essentially what you're going to do is using the kit contents and using sterile gloves, you're going to create a sterile field over the patient. In the kit, what you'll find is an airway adapter, the specimen cup, and what you're also going to find are 2 syringes and 2 vials of saline. And I'll go over the reason for that later. Then you're going to have your syringe, which I've already filled up with your saline, specimen cup, which we've already talked about, a needle to remove the saline from this vial, and a drape. This is the drape that you're going to go ahead and place over the patient for creating your quote-unquote sterile field. First point of order, what you want to do is increase oxygenation to 100% FiO2 for 2 to 3 minutes. Best thing to do is go ahead and put it at 100% while you're setting up for the procedure. Then, what you're going to go ahead, you're going to fill up your syringe with 40 cc's of saline, and most importantly, what you're going to do is leave a 10 cc airhead on here. The reason for this is the catheter has 2 to 3 cc's of hold-up volume in there, and what you want to do is clear out that catheter of saline and make sure that all the saline is in the lower lung so that when you aspirate back into your syringe, you've only saline in there that's touched the lower lung. Put your specimen container to the side, open up your Combicath, place it on the patient. What I'd like you to notice is there are also directions in here in the package insert. If you'd like to refer to those going forward, please do. Your Combicath comes in a sheath. This is also for sterile technique. Just like your closed suction system, when you start to funnel the catheter, you're going to push it out like this, and it's going to be a very similar kind of feel. Also, what it allows you to do is have the catheter back here, and if it hits your hip, you don't have to worry about losing your sterility. Now it's time to place your bronchodapter on. Again, this is a swivel adapter, which you've probably seen many times, and you'll place it right on the ET tube. You're going to continue to ventilate the patient, and this allows you to do so.
Cool.
At this point, you're ready to insert the Combicath. However, I'd like to mention there are many institutions throughout the U.S. that are doing this on fully awake patients, and there are many others who are increasing the sedation on their patients when they do this. At the University of Maryland, it's written into the protocol that you can go ahead and increase the sedation, therefore making it a little bit more comfortable for the patient. Obviously, what we're doing here is we're going down into the lower lung, which patients obviously aren't used to. So by increasing the sedation, it should lessen the cough response and also allow the patient to have a higher comfort level. Now we're ready to insert the Combicath. This is open, this sheath is open at the tip here, so what you're going to do is go ahead and simply funnel this down. The crucial part of this procedure is taking your time, being deliberate, yet not being overly aggressive. As you go down the ET tube, which is generally 30 centimeters, you can be as fast or aggressive as you want. You're obviously not going to hurt anything. It's that last 10 centimeters from the end of the ET tube down to the lower lung that you need to be very deliberate and careful. As I funnel this down, you can see me pulling back the sheath. The Combicath is a feel procedure. As soon as you meet resistance, you stop. If you think you're at the carina, you should stop. If you think you're in the lower lung, you could stop. It's for this reason you won't find any markings on the catheter. The company feels that if you meet resistance, the most important thing is to stop and assess where you are. If you think you're in the lower lung, then you move on with the rest of your procedure. If you get the feeling that you're at the carina, what you would do is pull back and then try to go back down again. When you get down there, feel this coming in, you'll feel resistance as you hit the lower lung. It's at that point you stop, as we talked about. You can then remove the sheath of this catheter. Be very careful when you take the sheath off. What happens sometimes is the Combicath, which is a dual lumen catheter, can actually remove the inner lumen of the catheter if you're aggressively taking that sheath off. So that's something that'll happen to you the first time and then maybe never happen again. Then what you'll do is you're down in the lower lung. You're semi-wedged down there, and what you need to do is remove the catheter 2 to 3 centimeters back. You're retracting it out of the lower lung for 2 to 3 centimeters. The reason is you're going to see this inner lumen of the catheter expel that plug, and it's also going to advance past the outer lumen 2 to 3 centimeters. Since you're already wedged up against the lower lung, you need to give that inner lumen of the catheter room to come out. Now what we're going to do here is we've retracted our catheter 2 to 3 centimeters. Go ahead and remove this spacer. This spacer is what keeps the inner lumen of the catheter from popping out that plug prematurely. This is now discarded, and now you will gently push down and advance that catheter. Give this a quarter turn here to lock it up here at the luer lock, and now what you've got is you've advanced the inner lumen of the catheter, and you've got a sterile tip on the catheter that's never touched anything but the lower airway. Now what you'll do, attach your syringe with saline, plunger up, and proceed to lavage. You'll feel a good bit of pressure on this. It's a very long, skinny catheter, and you're going to feel the lumen is quite restrictive. I don't know if you heard that there, but the air was the last thing to go through and cleared out the catheter and also allowed the catheter to be emptied. Now immediately go ahead and bring back into the syringe. A lot of times you'll pull quite a bit of air back here, and you'll also get some saline back as well. 2 to 5 cc's of saline is really all the lab requires here to do the test that they want to do. So once you get that, you're in pretty good shape, and you can go ahead, take your syringe off, which you've now got your sample in, place that down, and now remove the catheter. Now what we've also done is, if you'll recall, what we've done is we had also drawn up another syringe. If by any chance you don't go ahead and get that first sample back, for some reason the patient's very dried out and it is absorbed very quickly into the lower lung, you now have another syringe with which you can do a lavage and aspirate right back very quickly. So if you do the first 40 cc's and you can't get a sample back, you've got another syringe that you can put another 40 cc's in and aggressively try to get the sample back. And that right there is a very important point, because most times, especially as you get running with this, it'll be fairly easy to get 2 or 3 cc's back at least. However, if the patient is dried out, or if you're not wedged into the lower part of the lung, if you've retracted the catheter a little too far, you might have some issues there. So that allows you, without having to do a whole nother procedure, to just go ahead and attempt another. Now that we've got the sample in the syringe, you've got to get it ready to go down to the lab. Simply grab your specimen container, and I can't stress enough how important it is to use good sterile technique here. You don't want to bang the side of the cup or touch the tip of this syringe against anything. You simply want to hold it up, place it into the vial, and send this down to the lab. Just a couple troubleshooting techniques and things to look out for, especially as you get up and running with the Combicath. Some of the things that I see go wrong most often are, first of all, as people are retracting the catheter 2 to 3 centimeters to go ahead and leave room for that inner lumen to come out, a lot of times they'll take it out 6 to 7 centimeters, in which case they're far too out of the lower lung, no longer properly wedged, and can't go ahead and get a sample back because they're not even in the pool of saline that's down in there. So as you take that out, make sure that you're not retracting the catheter too far. The other thing I often see go wrong is sometimes when you're pulling back on the syringe to get your sample back, the negative pressure is pretty strong. People can sometimes tend to pull the catheter out of the lower lung as well. Make sure as you're pulling it out that you don't pull the whole catheter out, that you're just pulling on the plunger of the syringe. Sometimes it's possible that when you pull back on the syringe will get some negative pressure and you won't be able to pull out at all. 2 reasons that this could be happening. Quite possible that there's a mucus plug. Again, it's a very long, skinny catheter, so if mucus does get caught in there, it's a little bit difficult to pull it all the way up that lung catheter. In which case, you have a couple options. One, you can go ahead and do your second aliquot of saline, which you've already drawn up, and that way it'll expel the mucus plug and also allow you to do your syringe, pull back your syringe. The other one is you can start over and get a new catheter. Finally, the last thing that might help you out is, conversely, if pulling the catheter too far out of the lower lung, sometimes we don't pull it out far enough, or, which is in the beginning is very common, people forget that move altogether and don't pull out the catheter at all. In this case, when you expel the inner lumen, it's pushed right up against the cell wall inside the lung. If you feel like that's the case, go ahead and remove it about 1/2 centimeter, and that way it gives it room to fill up as you're pulling back on that syringe. Regarding the complications associated with the Combicath, they're few and far between. However, we do see some issues. About 8% of the patients you will see have a little bit of blood-tinged secretions come back. And we see this commonly in bronchoscopy as well as closed suctioning. However, it's something that shouldn't worry you, but it should be monitored. Additionally, in our last abstract out of the University of Cincinnati, 4% of patients experienced hemodynamic changes. However, all of them resolve themselves after 5 minutes without any further clinical treatment. Just to let you know, we don't see any hypoxemia in the last 3 studies we've done as well as the last abstract. The reason for this is, what we feel is we pre-oxygenate the patient at 100% FiO2, we keep ventilating while we're doing this procedure, and the 13 French catheter really isn't big enough to occlude the ET tube, so the patient is still getting some ventilation. Also, it's a very quick procedure. It takes roughly 60 to 90 seconds once you're down in that lower lung, in which case you get your sample and you're out. So therefore the patient should be able to tolerate that much time having the Combicath down in the ET tube. In summary, as you can see, the Combicath is a very simple and easy procedure to do. The entire procedure should take 8 to 10 minutes, and clinically speaking, it should have huge benefits for the patients in diagnosing BAP accurately, as well as proper use of antibiotic therapy.